So welcome. In this session, we'll be discussing about infective endocarditis. I will do a brief introduction, look at the pathogenesis, discuss the morphology, and look at some clinical features. Welcome all. My name is Maurice Bimiri, and I'm the Daktari. So, start. Now, infective endocarditis, which from now I'll be calling it IE, infective endocarditis, it is a microbial infection of the heart valves or the neuroendocardium, which leads to the formation of vegetations. And these vegetations are composed of thrombotic debris and organisms often associated with destruction of the underlying cardiac tissue. So I want you to note that in this case, the vegetations are non-sterile and there is destruction of the underlying cardiac tissue. So if there is destruction of the underlying cardiac tissue, I want you to think what effects can that have if you have destruction of the myocardium, underlying myocardium, and the affected part is part of the conduction system, arrhythmias may develop. Now, fungi, rickettsia, and chlamydia can cause endocarditis, but in a vast majority of cases, it is caused by extracellular bacteria. Okay, so note that. Let's move on. Now, endocarditis is divided into two. It has two forms. It's either acute or subacute. And this basis is based on the severity of the clinical cause, also the virulence of the causative organism, and also if we have an underlying cardiac disease. Now, let's look at acute endocarditis. It is necrotizing, ulcerative, invasive valvular infection on previously normal valve. So you need to note that it is a normal valve in acute endocarditis. And a highly virulent organism is implicated. And in this case, it is Staphylococcus aureus, okay? Staph aureus. Now, it has the severity of the clinical cause is it has a very poor prognosis with the death of the patient within days to weeks. Now, on the other hand, subacute is insidious, okay, and follows a protracted course on previously damaged valve. So here you need a damaged valve. The organism implicated here is of low virulence, and it is Viridans streptococci, okay? And the severity of the clinical course is that it has a good prognosis because patients recover on antibiotic therapy. Now, pathogenesis. Now, endocarditis can develop on previously normal valves, especially the acute endocarditis. But cardiac abnormalities generally increase the risk of getting endocarditis of the valves being affected by the bacteria. And such abnormalities include rheumatic heart disease, mitral valve prolapse, bicuspid aortic valves, calcific valvular stenosis, okay? Also, sterile platelet fibrin deposits, which are found at the sites of pacemaker lines, indwelling vascular catheters, or endocardium are at endocardium damage sites, which can be due to flow jets stemming from pre-existing cardiac diseases such as a VSD. Now, when you have a VSD, the flow jets, okay, if this is the interventricular septum, if you have say left to right shunt, this flow jet here will damage the endocardium, and that will lead to a formation of platelet fibrin deposits, okay? And now those sterile, at first they are sterile platelet fibrin deposits, they serve as foci for bacteriocidin and development of endocarditis. Also, host factors such as neutropenia, immunodeficiency, malignancy, diabetes mellitus or alcohol, and also in intravenous drug abuse also increase the risk of IE. Now, what is important to note in endocarditis is that you must have a preceding bacteremia. Okay, so it is important for you as the caregiver to note where the mechanism or the portal of entry of the causative agent. So it might be which might be elsewhere, such as a dental or surgical procedure, which can cause a transient bacteremia, or injection with contaminated materials directly into the bloodstream, such as in the intravenous drug users. Okay, so and the bacteria now will first cause a bacteremia, then the bacteria will seed in such as the sterile platelet fibrin deposits, and now that will cause the endocarditis. So let's look at some positive organisms. Now, Staph aureus is the predisposing conditions is intravenous drug abusers and native cardiac valve. So it does not require a cardiac abnormality for it to cause endocarditis. It is the causative agent of acute endocarditis. Then we have Staphylococcus epidermidis, which is a viridans streptococci. And the predisposing condition is patients having prosthetic or artificial valves. Okay, and please note that the aortic valve is the most commonly affected in prosthetic valve endocarditis. Now, Staphylococcus viridans, previously, it requires a previously damaged valve, so subacute. Staphylococcus mutans, patients who have had a recent tooth extraction. So the patient comes and tells you that you notice the patient has endocarditis after a dental procedure. You want to suspect mutants. Now, apart from those, we have enterococci and the HASEC group, namely H4 Haemophilus, A4 Actinobacillus, C4 Cardiobacterium, E4 Echinera, K4 Kingera. Okay, those can also cause infective endocarditis. Now, note that in about 10% of the cases of endocarditis, no organism is isolated from the blood, the so-called culture negative endocarditis. And this can be due to 3 reasons. Why? Previous antibiotic therapy. So the bacteria will not be in the blood or non-culturable amounts. Okay. Also, 2, difficulty in isolating the offending agent. Maybe the offending agent requires a special medium for growth. Okay, and one such is Bordetella, not Bordetella rather, Batonera henselae. It requires special medium, so you cannot isolate it on the normal culture mediums. Okay, so it will be said to be culture negative. Okay, also because the organism might be deeply embedded within the vegetation, so it is not readily released into the blood. So it is there, but it is not being released into the blood. Those are the 3 reasons which can explain culture negative endocarditis. So now, morphology of especially these vegetations. Now, the vegetations are usually friable, bulky, and potentially destructive, okay? And they contain fibrin, inflammatory cells, and microorganisms, okay? And they are found on the heart valves, especially on the cusps. Now, aortic and mitral valves are the most common sites for infection. So these are the left-sided valves. Although a cuspid valve is frequent target in the setting of intravenous drug abuse, because venous blood will first reach the right heart before proceeding to the left. So tricuspid valve is the most frequent target for endocarditis in intravenous drug abusers. Now, the vegetations may be single or multiple and may involve more than one valve. Okay, And sometimes they erode the underlying myocardium to produce an abscess cavity, the so-called ring abscess. Now, shedding of emboli, these vegetation, since they are friable, they can be shed as emboli, and this will lead to abscess formation at the site of where the emboli is lodged. So because these emboli are non-sterile, they contain the bacteria. So the bacteria, upon where it is lodged, it will cause an abscess. And this will lead to now septic infarcts and aneurysm. Aneurysms resulting from bacterial infection of the arterial walls, the so-called mycotic aneurysms. Okay. Now, the vegetations of subacute endocarditis, if you look at them, they have granulation tissue, and this will suggest chronicity. Okay. And that granulation tissue will develop, will promote development of chronic inflammatory infiltrates, will also lead to fibrosis and calcification over time. Okay. But they are less destructive. The vegetations of subacute endocarditis are less destructive as compared to those of acute endocarditis. Now, here I put you a table, and we are discussing this, the infective endocarditis. These are not the marantic, sorry. These are not the marantic. Marantic is non-bacterial. Marantic should be here. Okay, so it is around there. And the characteristic of those vegetation is that they are large, friable, that is easily detachable, bulky, irregular, and they are found on the upper surface of the cusps. They are non-sterile because they serve as the foci for the bactericidin, and they usually ulcerate or perforate the underlying valve there or the myocardium. Okay, so they are destructive in nature. And okay, so clinical features. I need you to understand fever is the most consistent sign of infective endocarditis, but in older patients or adults, it may be absent. Okay, so you need to look out for other clinical features such as fatigue, weight loss, flu-like syndrome, splenomegaly. Okay, those are the ones which you want to look out in an older adult because fever will be absent. Now, acute endocarditis will often present as a rapidly developing fever, chills, weakness, and lassitude. Okay. Now, cardiac mamas are presenting 90% of the patients with left-sided regions. Now, since the vegetations are friable, microemboli are formed, which can give rise to the petechial rash, that is, nail bed hemorrhages, the so-called splinter hemorrhages, retinal hemorrhages, the so-called rod spots, painless, I need you to understand that, painless palm or sole erythematous lesions, the so-called Janeway lesions. So Janeway lesions are red regions, and they're painless, and they're found in the palm or the sole. On the other hand, Osler nodes are painful nodules found in the fingertips, either in the fingers or on the toes. Okay. Now, diagnosis is confirmed by you need a positive blood culture, but also remember you have the culture negative endocarditis and echocardiographic findings. Okay. Then the disease is also diagnosed according to Duke's criteria. Remember, St. John's criteria. Now, this is Duke's criteria. Now, let me show you some of those. This is a Osler node, and this is painful. This is painless. The Janeway region is painless. Okay, but this is painful. This is the splinter hemorrhage. Okay, or the nail bed hemorrhage. This, you can see the retinal hemorrhages, the so-called rod spots. Okay, this is when you conduct a fundoscopy, you will observe the rod spots. Now, Duke's criteria, it has a major criteria, minor criteria, and pathologic criteria. Now, the major criteria is blood culture positive for the characteristic organism or persistently positive for an unusual organism, echocardiography identification of a valve-related or implanted mass or abscess or partial separation of artificial valve, or a new valvular regurgitation. So these are the three major criteria, and we have very many minor, which I won't discuss all. So in the minor, you have a fever, predisposed in heart region or intravenous drug abuse. You can also have microbiologic evidence, including a single culture positive for an unusual organism. Okay. Also vascular lesions, also glomerulonephritis, or the osra nodes or the rod spots present. Okay. Also the Janeway lesions, those are under minor criteria. Then the pathologic criteria, microorganisms demonstrated by culture or histologic examination in a vegetation, embolus from a vegetation or intracardiac abscesses. We can also histologic confirmation of active endocarditis in vegetation or intracardiac abscesses. Now, complications of this. Now, we have cardiac complications can include valvular insufficiency or stenosis, myocardial ring abscess, that abscess due to extension of the destructive nature of the vegetation, suppurative pericarditis, valvular dehiscence, okay, then embolic complications in the left-sided. This might lead to septic infection of the brain, spleen, kidneys. In the right side will lead to a lung infarct or a lung abscess. Renal complication include an embolic infarct, especially from the left side. Also focal, which is more common, or it can cause focal glomerulonephritis or diffuse glomerulonephritis, and that glomerulonephritis is due to the glomerular trapping of the antigen antibody complexes, okay? And it will present with hematuria, blood in urine, albuminuria, and renal failure, okay? Due to the myocardial ring abscess, there might be an arrhythmia due to extension to the underlying myocardium and conduction system, okay? So I think here are now some differences between acute and subacute, which I hope you can pause the video and look at them, and I hope they will be helpful. So pause the video here and look at them. So thank you for your attention, and follow for more of med content. Thank you very much.